It's time for our big question interview tonight. I'm joined by Health PS Dr. Nicholas Muruguri. Thank you for coming in. Just as a preamble to our conversation, of course, cancer is the third biggest killer in Kenya, and in a report aired yesterday here on Citizen TV, we saw the sorry state of cancer patients languishing at the Kenyatta National Hospital. Here to demystify it is Dr. Muruguri. I want to begin with a global picture of the state of the Kenyatta National Hospital before we talk about cancer treatment specifically at the referral hospital. And I do this because from time immemorial, Kenyatta has consistently been the one hospital that has been overwhelmed on all fronts. This is the country's largest referral hospital. And the question is it symptomatic of poor planning? Because certainly this being the go-to hospital, one would expect that government would be very keen on ensuring that there is commensurate growth, if you like, in terms of the hospital's facilities and equipment. What, in your opinion, is the problem?
First of all, need to appreciate Kenyatta is a 2,000-bed hospital, and for a long time it was only referral hospital before Moi referral hospital was established. Now, over the time, we have not been able to expand infrastructure commensurate with the growth of the population, and therefore for a long time everything was centralized around Kenyatta. Now, looking forward, we have to realize the problem in Kenyatta. Problem being that unless the peripheral facilities become functional, Kenyatta always have challenges of congestion. That is why you have seen the government try to decongest Kenyatta by ensuring that at least we have two properly funded and supported and equipped hospitals in each county. So at least 2 level 4, level 5 hospitals in each county that can offer fairly advanced care, so that we don't all of us have to come to Kenyatta. So part of the medical equipment project, the agenda was to decongest Kenyatta. And at that we have succeeded fairly well, and that's why we are trying to decentralize specialist services. What people have been going for Kenyatta is specialist services. So the more we decentralize that to counties, the more we are likely to see a better functioning Kenyatta. So unless county referral facilities remain functional, starting in Nairobi and peripheral facilities, Kenyatta will continue having challenges for a long time. So the solution for Kenyatta is really to ensure that all county referral facilities are functional, and more important, Nairobi primary health facilities function. Wherever you have a
funding challenge for Kenyatta, how much does it get in terms of annual budgetary allocation to grow the hospital?
Kenyatta get 13 billion. But money is not the problem in Kenyatta. It really is to ensure that the neighboring facilities, equally primary health facilities, remain functional. For example, with the looming threat of strikes in Nairobi, for example, and therefore primary facilities are not functional or do not offer 24-hour service, particularly primary health facilities. Remember the former municipal clinics, Jericho, Makadara, and so on. As long as they are not functioning properly, then Kenyatta will always have challenges. So Kenyatta problem, not necessarily money, of course. We don't have enough funding.
And that's 13 billion annually?
Annually, yes. But as long as the peripheral facilities don't function, Kenyatta is going to having a problem of congestion. So we have Kenyatta, for example, treating diseases should be treated at a health center and dispensary. Kenyatta should remain a referral facility. Are
you therefore saying, because you're saying peripheral facilities are not working, are you saying that the reason why we're seeing the influx of cancer patients at Kenyatta specifically is not because they can't receive that treatment at their county level, but it's because doctors are on strike?
No, not that.
Because that is the relation you've drawn. You said they're not functioning, we're having doctors on strike in Nairobi.
No. So the problem of Kenyatta is congestion, primarily because a lot of services that are supposed to be provided for a long time in peripheral facilities were not being provided there. So we have kind of concentrated specialist services in Kenyatta National Hospital. So the last 3 years, we have decentralized specialist services, particularly when we come to dialysis, cancer care, and so on. So
I'm talking about what you have said in terms of the proper functioning of these peripheral facilities. They have been stocked with equipment. We saw you know, last year talking very proudly about how county governments have signed on to the, the equipment scheme, etc. So if they're not functioning properly, in what way are they not functioning properly? Is it still a question of equipment? Is it personnel? What is the problem at the county facilities?
No, they are functioning, but what I was saying is that as long as we have not decentralized some of the services, particularly cancer care, what brings people to Kenyatta is basically radiotherapy services, looking particularly on cancer care. It's basically radiotherapy services. And that is why we have now a plan to decentralize, expand capacity in Kenyatta, at the same time start another center in Moi Referral Facility. That we have to through radiotherapy services being provided to the public population. Now, when it comes to other services, when it comes to chemo, for example, chemo can be provided in a level 4 or level 5 hospital. When it comes to surgical intervention, which is basically another key area of cancer care, that can be provided in mostly level 4 and level 5 hospitals. So the whole idea of medical equipment project was to decentralize specialist services to county levels. So until we build up capacity as we are continuing, particularly the issue of radiotherapy, you'll find congestion continues in Kenya. The solution is basically decentralize the radiotherapy services. As we are saying, we expand capacity in Kenyatta, at the same time start another radiotherapy services.
So are you saying sign on counties on another medical scheme an equipment scheme to provide radiotherapy services?
No, the radiotherapy service will be provided in national referral facilities, Kenyatta and Moi Referral. Those are national referral facilities. What we are going to build capacity within counties is for them to offer a certain level of cancer care, particularly surgical and chemotherapy, basically give them drugs to patients. When decentralize and build capacity of counties, then we'll find less and less patients coming to Kenyatta National Hospital.
And how exactly do you intend to do that? What is the plan? And if you would give us timelines on it.
So we have a two-pronged approach. Prong one is basically to expand capacity in Kenyatta National Hospital, basically having 4 new radiotherapy machines being available in Kenyatta. And at the same time start 2 radiotherapy machines, provide 2 radiotherapy machines in Moi Referral Hospital. That's phase 1. Yes. That's by end of June.
Okay.
And then from there, we have another plan to have 4 new centers over the next 3-4 years, basically looking at building our own capacity along those 3 years, and be able to start 4 new centers in phase 2. So phase 1 is key, because then becomes that they release the nodes of the whole cancer care. So we have 2 nodes, and then you have spokes, 4 spokes initially, and then build up capacity over time. The limiting factor in cancer care is basically human resource capacity and machines. But machine can buy any time. But the issue is to have enough specialists to provide care, and also enough specialists to be able to provide and maintain machine and so on. So we have a 2-pronged machine. One is provide care at the same time, build our own capacity locally to be able to then be able to equip 4 new centers.
I suppose the problem, PS, is that all these are, it sounds the same as a year ago, 2 years ago. We have this plan, we have that plan, and a date possibly in 2-3 years. It never sounds concrete, and it's difficult to hold government accountable to a specific date when you're saying you'll be able to roll this out. Can you give us more accuracy in terms of what will it take for you to be able to deliver all these centers you have talked about by, for instance, 2018?
No, first of all, just to correct you, our first commitment was to ensure they have 2 referral facilities in each county, 2 county hospitals that are well equipped. By end of next month, will be done in across 98 hospitals, 2 per county, plus 4 referral hospitals. That's the first phase of things. We have basically tried to equip and build capacity for public health facilities. So that is be done. Well, as regards the issue of specifically for cancer, our commitment to have 2 cancer centers in Moi Referral by June next year. And that is
by June next year. Okay.
It will be done by June next year. Because you see, for example, Moi Referral Hospital, they have a bunker. So we are going to go build an extra bunker and equip whatever they have. For Kenyatta, we are going to equip, build new bunkers, at the same time add them new machines. And that is work in progress. Now in phase 3, basically that is going to be expanding to 4 regional centers. That is now something will take between 2017 to 2020, building up 4 new centers. So the issue is not necessarily infrastructure; it's the issue to have enough human resource capacity. So in the next 1 year, we are also going to have our own training program in Moi University and Nairobi University, so we also start building our own capacity. In 3 years, we have specialists. We're ready to be able to man these 4 new centers that will be at sub-regional level.
How many specialists are you looking to train annually?
So our initial target will be looking at 10 in Moi and 10 in Nairobi University, so 20. And we have an intake of 20 over the next 5 years. So what will happen is the initial support, we are going to support Moi University and Nairobi University to start those programs. So already curriculums are already developed. And once they do that, then we are sure that in 3-4 years, we have our own specialists locally trained here.
And yet care is needed today. there are patients who cannot afford 4 or 5 years to wait for this plan to roll out. And when you look at the pictures of patients lying on the corridors, there is the feeling that basically health workers or the hospital are a little bit too accustomed to that level of pain that there's no response. You don't see the kind of effort or empathy that one would want to see a person who is in need of care receiving. How do you respond to that?
That's far from it. We need to appreciate and acknowledge that we have come from far. And we have challenges, that's true, but we have made also progress. And we take note of the current challenges we may be having in terms of the disease burden. We have, annually 40,000 new cases of cancer. And our capacity may be overstretched, but within a year or so, we are going to sort out this problem at the phase 1, and then build up capacity for the future in phase 2. So it's something that we're working on, and eventually our game plan is for Kenyatta, for example, we expand this capacity because they have the doctors. What they need is extra machines.
But I hope you appreciate what I'm asking, that even in a year, there are people who, sadly, whose images we're seeing may not have that 1 year on their watch. Is there nothing that the hospital can do, that government can do to help expedite their treatment?
We already have a program, for example, with Aga Khan that been supporting radiotherapy services for some patients. We are also, through expanding package NHIF, we are now able to offer, NHIF is able to support cancer care for its members in private sector facilities, and we have 9 centers that are able to provide cancer care in public sector facilities. That was a major step to try to decongest. For a long time, even NHIF members were forced to go to Kenyatta National Hospital. So once we are now expanded the package for NHIF, for example, we have been able to offload Kenyatta National Hospital significantly. At least for members of HIF, they can now go to other private hospital facilities and get care.
You're saying it was worse?
It was worse. It's better now, and of course, it's not that it's best.
That's what better looks like.
It's not that it's best, but we also need to appreciate we are making progress towards addressing this problem. We get 40,000 new cases every year. We get 30,000 people dying every year from cancer, largely because of late diagnosis, and this is why part of our strategy is to ensure that we can start a screening program. And this particular year, the government has put $1 million to initiate screening programs across all counties.
And your response returns me to my first question. You know that you're expecting 40,000 new cases annually. Is the problem that we're seeing not symptomatic of poor planning? That if you knew there are going to be 40,000 new cases, we shouldn't be seeing the images that we saw yesterday on our screens. The government should have put a plan in place to cater for that extra 40,000 cases that you were expecting.
I think the plans have been there, and I don't want to blame the past regimes. What we need to appreciate is now that the current government, Jubilee, has taken this issue head on, and we have a clear plan for cancer for this country. For prevention, for example, we'll soon be rolling out cancer prevention program, particularly human papillomavirus vaccine, that's going to address cervical cancer cases. We are going to have started screening programs to ensure that people are able to be diagnosed early, and then at the tail end of it is basically the treatment program, including palliative care. So we have a game plan for cancer, just the way we have done progress in HIV.
But as you've just said, plans have been there, execution has been missing.
Oh, I have no doubt with our capacity to execute. And you have demonstrated in exactly 15 months, we are able to equip 2 county hospitals in exactly 15 months. So even for cancer, come June, we'll be reporting progress we have made in addressing cancer.
Is there a case for some sort of possible criminal negligence on the part of government health facilities or health workers when you see people languishing like that in need of treatment and they do not have the very basics, such as a bed?
Really, we need to appreciate that...
Do you think there's no liability on your part whatsoever?
No, we are concerned, and Kenya need to appreciate that we know, for example, Article 43 guarantees everybody right to health. We know that. And that is why you have seen government of Kenya, Jubilee government, has invested progressively over the last year to ensure that that right is actualized. So it's a work in progress. We may not absorb all the problem in the health sector overnight. The CS is very committed, the government is very committed, the president is very committed to resolve the issues in the health sector, but we need to be patient. We are not going to solve the problem in the health sector overnight, and we have demonstrated in the past, for example, on public health disease, HIV, TB, malaria, it can be done. We are looking at decentralizing certain services like kidney dialysis. We have demonstrated it can be done. So we have a record of execution, and we are also going to just reassure Kenyans a little more time. We are going to solve cancer problem.
I think the unfortunate thing is that those who really you're asking to give you a little more time, they themselves are on the clock. The clock is ticking for them.
No, really, we need to appreciate the problem is big. We need to appreciate that something is being done about it progressively. They're being done about it. We have addressed all major killers of Kenya, and cancer is really the last end of things, and we are going to solve that problem as well. We are going to invest both in infrastructure, equipment, and personnel to ensure that the whole spectrum of cancer care, from prevention to diagnosis, to care and treatment, if all the palliative, we are able to provide care both at referral facilities and also at county level.
Let's finish on the question of cost of treatment, which has always been prohibitive, and specifically when it comes to drugs. What sort of partnership did Kenya explore with India upon the visit of its leader in terms of bilaterals and getting drugs at cheaper rates? This is a country that has perhaps one of the world's leading facilities in terms of producing generic drugs. Is there some sort of agreement that was reached specifically in terms of cancer?
So the agreement with India government was fairly broad, but the health sector was really one of the main beneficiaries. We agreed on equipping Kenyatta, for example, and the government did donate one radiotherapy machine to Kenyatta. We are exploring under that MOU potential role of private sector partnership, where we can be able to produce generic chemo drugs in Kenya. But also before that happens, we are also looking at potential role of Kenya Medical Supply Agency stocking cancer drugs, because they're able to buy in bulk. That reduces cost. We are also exploring some partnership, what we call drug access program. We already have two in place. One is with Novartis and Roche that allows us to access, for example, with Roche, cancer drugs for breast cancer at reduced price, 50% of the price, and we're expanding with other companies to ensure that we're able to have a drug access program as well.
Yes, and the news of that came out last year, but specifically in terms of producing locally these drugs and stocking, what are your timelines? What are you working with?
So at the moment, we are still trying to explore potential. There are two ways of doing it. One is have Indian companies come here and be able to produce locally. The other option is build capacity of our own manufacturers, and Kenya is a hub for drug manufacturing. And for now, we are not producing chemo drugs, but we should be able to produce chemo drugs in the near future. So the partnership with the Indian government was part of it, technological transfer, and also to allow partnership between county government, between our own manufacturers and Indian manufacturers. So we were giving ourselves 1 year to complete those partnerships. There was ongoing work going on, and in fact, both the President and Prime Minister of India committed to ensure that the MOU are executed, particularly in the area of health.
So you're saying 2017? Yes,
we should get something concrete. So far, there is ongoing discussion between ourselves and our counterpart in India. There's a role for private sector in Kenya. Because we want this to be driven by the private sector in Kenya, because it's a big potential for growth and partnership between private sector. We also want to leverage on the capacity of private sector in Kenya, and particularly in drug manufacturing.
Your plans sound grand and lofty.
It will be done. To be done, and we have demonstrated it can be done. You know, when we started with the medical equipment project, people doubted our capacity of government to execute. In 15 months, we have done it. Today, as we speak here, we had a patient for dialysis. They give an example today that he used to come to Kenyatta every day, twice a week. Now he's been dialyzed way back in Kisii, and that story is repeated in 47 counties, and we are counting. So and so on. So we have demonstrated that Jubilee government can plan and execute. So cancer, we shall deal with it.
Can only hope you do that quickly.
Yeah.
Thank you for your time. We're taking a short break, and the big question, we're back in a moment.